We're going to now proceed with our final lecture of the gynecologic portion of our conference today. And it's with pleasure that I introduce to you Lucy Caroma, who is a board-certified nurse practitioner who received her Master's of Science in Nursing from the Vanderbilt School of Nursing in 2005. She joined the reproductive endocrinology practice at Harvard Vanguard in Boston before settling back in Nashville to join Vanderbilt Center for Women's Health Practice. Spending 8 years at Vanderbilt in addition to a busy practice, Lucy also played a major role in education for the Department of OBGYN in the School of Medicine. And besides vulvar dermatoses, her clinical interests also include PCOS. In addition to speaking at conferences and lectures to residents, Lucy's published and reviewed many chapters on infertility. Before moving to Louisville in 2019, she practiced in the Division of Gynecologic Specialties at Johns Hopkins and MedStar. So I'd like to introduce now Lucy to speak to us on pelvic pain and the adolescent question. Don't forget to send your question and answers on the computer, and we will bring them up at the completion of Lucy's talk. Lucy?
Good to be the first presenter after a break. Everyone is fresh and ready to talk about pain. Thank you, Maggie and Kim, for great talks this morning. Thank you, Dr. Hertwick, for the kind introduction. Now let's talk about Ellis, who is a 14-year-old female who presents with her mother complaining of worsening period pain. She started her period at age 12. At first, her periods were irregular and painless. For the past year, she reports monthly painful cycles lasting 5 to 7 days duration. Pain starts 1 day prior to the onset of menses, lasting through cycle day 4. Pain is the worst on cycle day 1, making it difficult for her to function, causing her to miss school and or requesting early dismissal. Ellis often lays in a ball on the floor, complaining of nausea and vomiting with her periods. She rates her period pain as 10 out of 10. Ellis has a difficult time swallowing pills. Her last period was so painful that mom crushed Midol up and placed it in applesauce. However, Ellis reports no improvement in her pain. She has no past medical history, no family history of endometriosis. Mom is concerned about Ellis starting birth control as she isn't sexually active, and mom did not tolerate contraception. How would you address Ellis and her mother's concerns? So I'll give you a couple more seconds for anyone else who wants to answer. Karen, if you want to put up the poll results. Okay, so interesting poll results. Hopefully you'll walk away from my talk with some pearls on how to help treat adolescent patients. And so the objectives of our talk today are to perform an appropriate history and evaluation of an adolescent with pelvic pain, state the gynecological causes of acute and non-acute pelvic pain, and understand when to refer to a pediatric and adolescent gynecologist. I have no disclosures related to the content of this material. And so let's define the problem. 20 to 90% of adolescents will have significant dysmenorrhea. 5 to 15% will have severe pain, causing them to miss school and or other activities. Primary dysmenorrhea is defined as cramping that occurs just before or during menstruation in the absence of other diseases, while secondary dysmenorrhea is defined as painful menses due to pelvic pathology or a recognized medical condition, with endometriosis being the most common. While chronic pelvic pain is beyond the scope of today's lecture, I just want to remind you that that is considered to be pain in the pelvic area that lasts 6 months or longer, and that can be constant, intermittent, cyclic, or acyclic in nature. And so usually the onset of dysmenorrhea occurs 1 to 3 years post-menarche. They will begin to experience crampy lower abdominal pain each period. Cramping can start 1 to 4 hours prior to menses onset, lasting 24 to 48 hours in duration, although it often starts 1 to 2 days premenstrual and can continue through day 4 of their period, with usually the most painful being the first 2 days. So the takeaway of this slide, while we aren't focusing on secondary dysmenorrhea, is that these are risk factors or symptoms for endometriosis, which is the most common cause of secondary dysmenorrhea. So severe pain that starts immediately after menarche is concerning because painful menses commencing after menarche is unlikely to be primary dysmenorrhea, as most females are anovulatory for several months to several years after starting their period. Progressively worsening dysmenorrhea, an increased incidence, 7 to 10% noted in first-degree family members of women with endometriosis, having abnormal uterine bleeding, both heavy and irregular, having mid-cycle or acyclic pain. So in adolescents, the endometriosis is 50 to 70% higher in those who don't respond to conventional medical therapy. Some other causes for secondary dysmenorrhea could be congenital anomalies or painful intercourse. And so historically, the etiology of primary dysmenorrhea was poorly understood. Pickles first suggested that dysmenorrhea might be related to a menstrual stimulant found in human menstrual fluid that stimulated smooth muscle contraction. However, later studies found it was a mixture of prostaglandins PGF2A and PGE2. PGF2A mediates pain sensation and stimulates smooth muscle contraction, while PGFE2 potentiates platelet disaggregation and vasodilation. And so pain can be accompanied by any number of symptoms, such as nausea, vomiting, and diarrhea, which can cause changes in bowel patterns. They also can have headaches, backache, muscle cramps, thigh pain, sleep disturbance. Pain often creates difficulty falling asleep and or waking up throughout the night, as well as generalized systemic symptoms such as fatigue, dizziness, anxiety, or nervousness, and even syncope, although rare. And so it's important to take a good menstrual history when the patient is complaining of period pain. You want to ask her, is she missing school? If so, how many days? Does she miss other activities, social events? Does she feel disadvantaged compared to her classmates? What medications has she tried? After asking patients about prior medication use, it's very important, as many adolescents have tried over-the-counter medications in subtherapeutic doses and have come to the conclusion that over-the-counter medications are unhelpful. This gives you a chance to start re-education from the beginning of the visit. You want to ask her, what makes the pain better or worse? Does her mother or sister have cramping? And is there a family history of endometriosis? So initial evaluation of all patients should include a medical, gynecological, menstrual, family and psychological evaluation. You know, we have all our kiddos fill out a PHQ-9 score. And so what is the nature of the mother-daughter and family interaction? This is a tip-off for us to look into other causes for pain. Sometimes pelvic pain in the adolescent is a very useful first step in identifying much more important underlying issues that could be missed. Patients with increased life crises experienced greater severity of symptoms in comparison to other adolescents. And really, it's because the cyclical repeated pain and the anticipation of the repeat pain causes greater anxiety. And adolescents may not bring up their fear or up their pain for fear that they will need a pelvic exam. One other thing that you may want to think about is you have to think about prior ongoing sexual abuse that can manifest itself as pelvic pain. And so the exam is not really important if the patient is not sexually active, or if they are, or if they don't tolerate a speculum exam. A Q-tip exam can be performed to examine for the presence or absence of hymenal abnormality. An ultrasound can also be useful if suspected uterine or vaginal anomalies. So the goal of treatment for primary dysmenorrhea is really to ensure that adolescents are able to effectively manage their symptoms and continue everyday activities with minimal disruption. Dysmenorrhea is the leading cause of recurrent short-term absences from school, and we know that school absenteeism leads to the detriment of an adolescent's learning and socializing. 12% of adolescent girls and young women aged 14 to 20 years lost days of school or work each month. 25% self-administered pain medication monthly without having seen a provider for further investigation. And 66% of adolescents unresponsive to medical therapy who undergo laparoscopy will have endometriosis. And so in a 2015 study of adolescent girls, average age of 17.2 years, with laparoscopically diagnosed endometriosis, many presented with acyclic non-menstrual pain, with 56% reporting at least one GI symptom, 52% reported at least one GU symptom. There was an association with PMS and an increased risk of depression and anxiety in adolescents with dysmenorrhea. So you have to remember that parental modeling may also play an important role in how a young patient reports and perceives pain, as well as their anxiety about experiencing pain. Pain affects how one shows up in the world. Some girls can continue to exercise, go to work, school, play competitive sports while cramping, and others can't. And really it's about getting them back to function. So carefully explain the nature of the problem to the patient and give her a chance to ask questions regarding her anatomy. For the medical management of dysmenorrhea, what seems to help patients the most is having an understanding of the process, along with how medications can help them in relation to their pubertal development. Have the patient keep a pain, mood, and or menstrual cycle diary. So as time goes by, she can see her improvement, giving her a sense of hope that the medication is working and she's getting better. And I often have them bring their diaries back at their subsequent visits so that we can look at their improvement over time together. I have attached a paper copy of a pain diary, but as we know, adolescents are very digital these days. And so, having them download a period app, you can get the same information. Patient education is key due to the prevalence of self-directed medication use leading to subtherapeutic treatment secondary to incorrect interval dosage and timing. So you really want to focus on the initiation of NSAIDs at the onset of pain, not at the onset of menses, because as we know, NSAIDs interrupt the cyclooxygenase-mediated prostaglandin production. Medication use is most effective when started 1 to 2 days before onset and continued through 2 to 3 days of bleeding. And so pain relief was seen in 67 to 85% of patients on an NSAID alone. Giving patients with severe pain, consider giving patients with severe pain a loading NSAID dose. Greater than 95% had relief with dual therapy of an NSAID and an OCP. We know that patients vary in their response to a particular drug, perhaps because of differences in pharmacodynamics. But if a patient fails to respond to an NSAID of one class, it is reasonable to switch to an NSAID of a different class. Surprisingly, different NSAIDs have different levels of pain resolution for different patients. And a lack of response to one NSAID does not mean the lack of response to another. So we all know there are many different choices for NSAIDs. Normally, salicylates are not utilized for dysmenorrhea as they offer no reduction in prostaglandin synthesis. What's most important is the timing, dosing, and continuing to take the NSAID. You know, how many times do you have a parent or a kiddo tell you that they took ibuprofen once and it didn't help their pain? And so really re-educating them about, you know, the consistency is helpful and important. And so mefenamic acid is unique in that it both inhibits prostaglandin synthesis and blocks the action of prostaglandins that are already formed. While phenamates can be costly due to only one company manufacturing the drug, it does control dysmenorrhea and is FDA approved to treat dysmenorrhea. Concomitant use of an H2 blocker or proton pump inhibitor, you can consider the concomitant use of an H2 blocker or proton pump inhibitor to decrease GI side effects. So some patients and families will come in seeking complementary and alternative therapies. We also know that adolescents should be asked what alternative treatments they may already be using. In addition to traditional Western medical therapies, patients should be encouraged to exercise, eat a well-balanced diet, get enough sleep, and work to reduce stress in their lives. However, there's limited data on the benefits of exercise and heat therapy for the symptoms of dysmenorrhea, but it's low risk of harm. Plus it has general health benefits, so I do tell patients to continue. We know that cognitive behavioral therapy is one of the most commonly used studied psychological interventions for pain. And a CBT program targeted at the treatment of pain helps with both symptom reduction and stress management. We're fortunate here at Norton to have the Children's Health and Illness Recovery Program, which has been well studied to facilitate recovery of functioning in teens with chronic illness. So the transcutaneous electrical nerve stimulation, or a TENS unit, acupuncture, herbal preparations, and yoga, while they have demonstrated some improvement in dysmenorrhea in some studies, current evidence does not support the use of them as first-line treatment. So when discussing hormonal treatment, I really try to emphasize to the parent and adolescent that the non-contraceptive benefits of birth control and that this truly is medical treatment. The decision to use one method over another should be patient-driven. And really the mechanism of action is that this has the prevention of both endometrial proliferation or ovulation or both, thereby decreasing prostaglandin and leukotriene production. So both cyclic and continuous oral regimens treat dysmenorrhea. Dysmenorrhea is substantially, if not completely, alleviated by anovulatory cycles and reduced flow. Continuous regimens may result in a more rapid onset of pain reduction. And if your patient has a contraindication to estrogen, or, this is better for them, continuous norethindrone acetate at 5 milligrams is equally as effective as a cyclic combined hormonal contraceptive. But you have to remember to remind the patient that this is not a contraceptive. So parents often ask, does she have to continue hormonal treatment forever? And the answer is no. Sometimes I suggest taking a drug holiday over the summer break when school attendance will not be disrupted. Patients will often experience anovulatory cycles for a couple of months after discontinuing treatment before pain reoccurs. But often adolescents don't want a drug holiday because they see how much better they feel. In general, if a patient goes 3 to 4 months with maximizing medical therapy and there's no improvement in pain, it's definitely time to refer to a pediatric and adolescent gynecologist for the possibility of a laparoscopy to exclude endometriosis or other causes. So our take-home lessons today are do not normalize symptoms. Dysmenorrhea that fails to respond to conventional treatment is not a normal occurrence. Adolescent women should not be led to believe that they have to endure pelvic pain. And so let's get back to Ellis. And so do we have the poll results? Okay, so 70% said that they would recommend option, sorry, let me advance the slides. Okay, 70% said that they would suggest A, and my thought that this was not the right answer is that Ellis's pain is a 10 out of 10 that didn't respond to Midol. While we know there are different formulations of Midol, you could suggest she try ibuprofen, but I don't know that this is going to alleviate her pain when she has that high of a pain score. You could choose option B, but again, Ellis's pain is 10 out of 10, and she's probably going to return in 3 months discouraged as she can't exercise on her period due to her inability to function. You could choose option C. You could prescribe an OCP, taking it in a cyclic fashion to see if Ellis can be compliant with the pill while also maximizing pain relief by having her start the ibuprofen 2 days prior to the placebo pills. But I think option D is probably the best choice in having her take it in a continuous fashion, as Dr. Human showed us, to really shut her cycle down, giving her the best chance of controlling her pain. Because really, our goal is to get these girls back to living their best lives. Thank you.
Lucy, thank you for your talk on pelvic pain and dysmenorrhea. We have a question: is Tylenol cyclic along with ibuprofen, does that work better than higher doses of ibuprofen only? What are your thoughts on that?
Okay, so my thoughts are that yes, alternating Tylenol and ibuprofen, you can try that, but does that work better than ibuprofen alone? Possibly, but I often think that we're using ibuprofen for short durations of time, and that if we can, in Ellis's case, I would say if we could really manage her pain by getting her cycles shut down, that probably would be a better option.
In cases that aren't like Ellis's, what would be your recommendation for just using, over-the-counter medications?
Yes.
Someone who doesn't have pain that's
Right.
10 out of 10.
Yeah. So, if patient has, 3 to 4 out of 10, I think absolutely using over-the-counter medications, alternating Tylenol and ibuprofen can definitely be a good choice.
What would be your maximum dose of ibuprofen that you would use?
I would say, well, I guess it depends on the age of the patient, their weight, and but I would say the maximum dose is probably 800 milligrams TID.
Okay. We have another question. Given how common irregular periods occur, timing the start of ibuprofen 1 to 2 days ahead can be problematic. How do you typically handle that?
Yes. So in those cases, I try to suggest using a birth control pill as part of the medical management of their pain, so that then the adolescent has a better, they can anticipate when they're going to be starting their period and when to start the ibuprofen in relation to that.
So basically, are you saying that that is a challenge, that you're not always going to be able to do that? And that might be an opportunity to engage the family in saying it might be easier for us to time this where we better able to cycle your child.
That's correct.
And I'll just reiterate what Lucy said is that, birth control pills, if we put all these lectures together today, have very low risk in the adolescent population. And we now see birth control pill use as medicinal in purposes. And based on the choice study that Dr. Dwiggins brought up, it's really not the best contraceptive. So the way I typically sell this to parents is consider this birth control pill as medicine, not birth control. In fact, if your child were coming to me for birth control pills would not be what I would choose.
Right.
I would choose a long-acting method of birth control, like an implant or an IUD that Dr. Dwiggins mentioned earlier, is much more effective and are the top 2 choices for birth control for adolescents. And referring back to the pain issue, there have been studies that compared nonsteroidal anti-inflammatory use alone, heat alone, and in combination. And it has been demonstrated that the combination of topical heat with something like a Thermacare heat patch will be additive to the use of nonsteroidals. So I often ask parents to pick up those Thermacare heat patches, and that way the child can apply them, take their ibuprofen, and go to school and have the heat with them through an entire school day. And that can be very effective.
Yeah. The Thermacare heat patch will last for up to 8 hours, which would get them through their school day.
Thank you, Lucy, for a talk, very succinct and nicely done.